Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, hello there, Dr. Roberson.
Dr. Reznick, how are you doing out there on the West Coast, my friend?
Good. It's a lot of June gloom out here. It's been in the kind of clouding in the upper 60s for the last week or so.
Not here. We're already starting to touch 90. It's just the sweltering heat and humidity is starting to kick in, my friend.
Yeah. Our deserts are hot, but most of the metropolitan areas, Orange County, beach, they're definitely June gloom weather. So that'll burn off hopefully soon.
Yeah. Well, we've got the sunshine and the heat going on right now. How have you been? How's everything in the practice?
Good. We're keeping busy.
That's right.
No complaints. It's perfect for me. I'm there 3 days a week, and got my schedule full every day that I'm there. So that's good.
Well, speaking of being busy, Jay, it sounds like the FDA has been busy this past month.
Oh, they sure have. Can you believe how many new drugs were approved in May?
I'll let you tell our listening audience just how many.
Okay. There are 17 new drugs that were approved by the FDA in May. Fortunately, we're not going to talk about all 17. We've narrowed it down to 7 that have some relevance to people who are in dental practice.
But Jay, before we get on that, I'd just like to mention just a couple of the ones that didn't make tonight's cut.
Mm-hmm.
And, one of them is Abrixvo. Mm-hmm. And that's an RSV vaccine. Mm-hmm. Okay. Yeah. So if everybody remembers, we had a bad season of RSV.
Yeah.
Respiratory syncytial virus.
Yeah.
Okay. The other one is another one called Arexi. So 2 RSV vaccines in the same month. So,
so we'll be ready for next winter.
Absolutely. Because, so since we're talking about drugs, audience, what drug was a major shortage due to RSV? Amoxicillin.
Yeah.
Yes.
Yeah.
So that hurts us. Another drug that came out was Euflymo, which is a rheumatoid arthritis biosimilar.
Uh-huh.
And then there's Viaza, which is for hot flashes, menopause. Then Zacdura, which is for Acinetobacter pneumonia. So those were some of the other drugs that came out. But again, I like to stress to everybody, it's something that we've said on the show all along. All right, now, so this is 17. Last month we had about 5 or 6.
Yeah.
But on average, it's about 100 drugs a year. So if you've been out 5 years, that's 500 new drugs that you are going to have to know before you treat a patient.
Mm-hmm. Because probably a good portion of them have some effect on your treatment. Either the drug affects what you do or what you do affects the drug or what you prescribe to the patient. So it's important to know all these, what the drugs are and what the interactions are.
So and Jay, today, I treated a patient that was on probably at least 8 psychotropic drugs.
Uh-huh.
Okay.
I had one of those last week. Yeah.
And so I think the audience knows what, some of our prescribing habits. I'm a big fan of tramadol, but why, audience, would I not prescribe tramadol with somebody with this many different psychotropic drugs?
Mm-hmm.
We're talking about SSRIs, SNRIs. So my biggest concern in prescribing something like that, Jay, with tramadol would be a serotonin syndrome.
Yeah,
that's right.
Absolutely.
So I switched to a low dose hydrocodone instead.
Okay, so, on those patients.
Now, could it not have happened if I still prescribed? Absolutely.
Yeah.
But I didn't want to take a chance.
Yeah.
All right.
I rarely prescribe any narcotic anymore, any opioid, since the Tylenol, acetaminophen, ibuprofen combination works so well, and study after study after study, whether it's in emergency medicine, orthopedics, oral surgery, shows that even works better than Perca. You've heard that before. Yeah. Now, patients, I'm allergic to every Vicodin, all this, but I can take that Perca. Yeah, that Perca drug. What is that? Yeah.
Well, and again, I'm a big fan of Toradol and
Mm.
Tylenol as well
Yeah.
too.
Yeah.
So
Good combo. Yeah. So I guess we should bring in our slides.
let's do it.
Go. Welcome to PharmaDocs, everybody. And this is our June 9th, 2023 edition. And
Yes.
we are pleased to be sponsored by iCore Connect and iCore RX,
Yep.
which are companies, actually obviously related companies, that help you with your electronic prescription needs. So you can prescribe from your phone, from your computer, from your practice management system. They have lots of different options. So
Yes, they do.
if you don't have any prescribed system already, it's a good one to check out.
And they're getting into all of the state dental associations as well too, Jay.
Yeah.
27, 29 of them already, I believe.
Yeah, I think just about every state now requires electronic prescriptions.
Absolutely.
Yeah.
Yeah.
All right. So our first drug today
Yes.
is Lumryz, which is sodium oxybate.
Correct.
And so this is a once nightly formulation that is actually a powder that's added to water to treat the cataplexy and excessive daytime sleepiness that's seen in adult patients who have narcolepsy.
I want you to think how bad that can be, having narcolepsy.
Yeah.
Not able to sleep at night.
Yeah. Yeah. I mean, they fall asleep during the day. In fact, narcolepsy is a fairly it's uncommon but common neurological condition where
Correct.
patients become abnormally sleepy, sometimes at the drop of a hat, and they can just lose muscle tone and fall asleep wherever they are. And there's usually very little warning. And so what this drug does is it's actually a sodium salt of GHB.
Yeah,
and GHB
oxybate. That's right.
Is it's a party drug, which is a Schedule 1 controlled substance, which means it has no medical purpose and has a high addiction potential, and it's used for in recreationally because of causes euphoria, relaxation. People think it makes them more social. It increases their sex drive, and so it's again, not a fairly common, but one of those party drugs that you hear about all the time. Lumryz is not a Schedule 1, obviously, because it does have a medical purpose. It's a Schedule 3 drug.
Yes.
And the way that it works is it basically induces sleep when the patient goes to bed, so that when they wake up, they've had a better night's sleep and they're not as sleepy during the day.
Right.
So
it works off GABA as well too. Gamma aminobutyric acid.
Yeah.
And of course, that's where we get our benzodiazepines from. Okay, because
exactly that's where they are.
Our drug midazolam, that's where it works, and Valium as well too.
Yeah, and as well as Xanax and
that's right,
all the other, all of those drugs. So it's an interesting drug the way it works. It's a powder that has to be mixed with water just before the patient goes to bed.
Right.
Because it'll induce sleep within a few minutes. Sometimes within 5 minutes, the patient drinks this, and within 5 minutes they're completely asleep. So patients have been injured by taking it a little too soon, getting up, going to the bathroom before they crawl into bed, and they pass out on the floor and hit their head, and end up in the hospital. So this is something that has to be taken just right before the patient goes to bed. And it can have some very serious side effects because it is a CNS depressant. And so patients who have narcolepsy, who are given this drug, you really have to, the physicians have to assess how it affects them during the day. It may affect their driving, their ability to operate heavy machinery, and those kind of activities.
Yeah, because it's important. Like if you do, or truck drivers as well too, they suffer from narcolepsy, because I mean, this could be a major issue, falling asleep, and because normally those guys log in about 8 hours a day in one of those tractor trailer rigs.
Yeah. Yeah. I think I passed out after driving for about an hour.
Yeah. Not a good thing.
Yeah. So this drug, because of how it works and how, because it's such a CNS depressant, is not available except by certain protocols. It's called the Lumryz REMS, Risk Evaluation and Mitigation Survey. So patients have to register for the REMS to be eligible to receive this drug. Healthcare practitioners have to be specifically certified, as do the pharmacies. So it's very tightly regulated, controlled, and lots of data is taken.
Well,
And
I
so,
mean, Jay, when you look at how this works, how fast this works, it's got to be regulated.
yeah.
I mean, you just can't start writing prescriptions left and
Yeah.
right. Or
Yeah, well, we can't. You've got to be specially certified in order to
That's right.
prescribe it. Yeah. So as far as dentistry goes, there are a lot of precautions because of the interactions that it has with just about any type of CNS depressant. So, anything like if we give our patients post-operatively an opioid analgesic, if we give them benzodiazepines, if we give them IV sedation, if we give them a muscle relaxant for their myofascial pain syndrome, those can all interact with Lumryz and cause all kinds of, enhanced CNS depression, such as depressed respirations, decreases in alertness, syncope, sometimes seizures and coma, and of course, even death because of respiratory depression and airway obstruction and
Jay,
hypertension.
Okay, so this is a great point that you bring up, because again, we go back as a practitioner, you got to know what Lumryz is.
Yeah.
All right. Because that patient is probably not going to go in there and say, "Hey doc, I take it for narcolepsy and all this."
Yeah.
So, oh, okay. So you can't sleep at night.
Yeah.
Well, okay. And you do a surgical procedure and you prescribe, like you just said, an opioid for that.
Yeah. Or you give them some oral midazolam or Xanax to take a half hour before they come in.
Yeah.
And you have an unconscious patient when they
you could have respiratory depression or arrest.
Yeah.
Okay. All right.
Yeah. So it's real important, because patients may not bother to put down that they have narcolepsy or they're on this medication. There was a study done, actually multiple studies done in the late 90s, where it was found that like at least 45% of patients will lie or leave out items on their medical history because they're afraid of being kind of known that they have this disorder, or they're using this substance, or they don't want it to go on their insurance, or they feel embarrassed. Or the other thing, for dentists, they don't feel that we need to know about it. And so you've always got to make sure that you go through the medical history. Don't just go through the page. Ask the patients after you've looked at their written medical history. Ask them again, any medical problems that you did not list on here. It's important that we know. We talk about how cannabis affects IV sedation and general anesthesia. It's like a hot topic now in anesthesia. And I had a patient who I saw last week, I think, for an implant consult, and we're going to do it with IV sedation. And, on his medical history, he doesn't smoke, he doesn't drink, he doesn't do any recreational drugs. And so I asked him about that again, just to verify. And he said, "Yeah, but I'm a musician, so a lot of people I hang out with, do those things, but I don't." And so that's pretty odd for a musician not to be involved in any of those activities. I said, the reason we need to know is that cannabis interferes, A, with wound healing, B, with our anesthetic, and C, with airway reactiveness.
Yeah.
And so, okay. So finished the consultation. My staff member went in to go over the fees and do the scheduling. And she comes into my office and says, "Oh, the patient wants to talk to you."
Yeah, he's ready to tell you the truth.
Yeah, now and he said, I smoke pot pretty much every day, multiple times a day, which, I had my suspicions. He's a musician.
Well, Jay, we even with this drug here, because like you said, they may be non-compliant with us,
Mhm.
and then you prescribe an opioid,
Yeah.
and then something happens, and then they're going to come back and say, well, I trusted my dentist.
Yeah.
He told me to take this narcotic at night if I started having pain.
Yeah. I didn't
And
know it was going to interact with.
I didn't know it was going to interact, or the
with a sleeping
wife,
pill.
or the spouse, I should say.
Yeah.
Hey, we're in the hospital due to the drug you prescribed. What are you talking about? Oh, well,
Yeah.
he's on this other drug, Lumryz, and you prescribed an opioid, and he went into respiratory arrest.
Yeah. Yep. So we got
to think about that.
You got always question your patients.
Yes.
Just look, as Ronald Reagan used to say, trust but verify. Look at go over the medical history in detail with your patient, and then ask them again. Is there anything that you left out, and why we need to know about it?
All right. Let's talk about Elfabrio.
Okay. So let's move on to Well, actually, I want to go just back and say that with Lumryz, there are 339 drugs that are known to interact with it.
Oh, gosh.
6 diseases. 242 of these interactions are major, 97 are moderate, and the rest there aren't anymore.
And so, how do you keep up with those 242 majors?
So basically, any CNS depressant.
Yes.
Yeah. Okay. So let's move on to our next drug, which is Elfabrio. And so this is a enzyme replacement therapy.
Yes.
It is an orphan drug because it's for a disease that is not very common, known as Fabry disease. And so what this is a hydrolytic lysosomal neutral glycosphingolipid specific enzyme known as pegunigaliside, alpha-IWXJ. Okay, which is a mouthful. So Elfabrio is easier to remember.
Yes.
This is an enzyme replacement therapy. It's an additional enzyme replacement therapy that there are some on the market already for Fabry disease. And what Fabry disease is, an enzyme deficiency disease, obviously, if we're treating it with enzyme replacement. But it's a deficiency of an enzyme that breaks down something called a fat called GB3, triacylceramide. So GB3 into smaller components so the body can use it for energy. And when that enzyme is deficient or absent, what happens is these fatty deposits will deposit in blood vessels. They'll deposit in large blood vessels. They'll deposit in small blood vessels. When they deposit in the small blood vessels, they can cause things like peripheral paresthesias, peripheral pain in the extremities, cold intolerance, dizziness, sometimes flu-like symptoms. And if they block the larger vessels, then you're looking at heart failure,
end organ failure,
renal failures is very common, or heart attack, stroke, and kidney disease. And there are 2 types of Fabry disease. There's type 1 and type 2. And type 1 is known as kind of the classical, or the classic. And this is the one that is discovered in children and adolescents. They discover early, they have symptoms early that lead their pediatricians to suspect that they may have Fabry disease. And so with these patients, before the advent or before the introduction of some of these enzyme replacement therapies, these patients had a pretty miserable life. And had a very high mortality and very rarely survived past 40 years old. The other type 2, is what they call later onset, and that's usually discovered in early adulthood, sometimes a little bit later. It's 5 to 10 times more common than type 1, and it is more characterized by the same early symptoms, but also the other symptoms of major vessel disease like heart attack, stroke, and kidney failure. So this is given by IV infusion every 2 weeks.
You know, Jay, you said something that we continue to always discuss about patient risk factors.
Yeah.
Because patients are living longer.
Mm-hmm.
Like with type 1, they didn't make it past the fourth decade of their life, okay? Or they got the late onset portion of this disease. Regardless, drugs like this will extend their lives.
Yeah.
People like this still go to the dentist.
Right.
All right.
Yeah.
This is going to be a compromised patient that comes into your office.
So when they write on their medical history they have Fabry disease and you don't know what that is, it's not something that you ignore. It's something you need to look up and need to be familiar with. And if they haven't written down what medication they're taking for it, you need to ask them. You need to ask them if they're on enzyme replacement therapy, because they are at much higher risk of occlusive vascular disease than other patients.
And then the physician that's managing this disease, then if you feel uncomfortable, a medical consultation is necessary. Notice, Jay, I didn't say medical clearance.
Right.
Because there's no such thing as saying, hey, I'm going to call the physician and get medical clearance.
Yeah.
No, it's a medical consultation.
Yeah.
You being the dentist will make the final decision based upon the recommendations from that physician.
Right.
If I'm going to treat that patient or not.
You make the final decision.
Correct.
Just because the physician clears them for the procedure doesn't mean necessarily that that's a wise decision, because physicians don't understand anything about dentistry.
No.
And
again,
course,
they're not going to say, hey, I cleared him or her to have surgery in your office.
Yeah.
They're going to give you recommendations, and then based upon that, you make that decision.
Yeah. Are they appropriate decisions?
Yes.
No. Okay. And so the biggest complication or issue with this drug, with Elfabrio, is that the incidence of infusion reactions is very high. So every 2 weeks when patients get this drug, they've got to be pre-meted with something like an antipyretic like acetaminophen or ibuprofen, plus an antihistamine, and sometimes a corticosteroid on top of that.
Why? Because of anaphylaxis.
Yeah. Or at least a less severe reaction like rashes, sometimes difficulty breathing, pain, fatigue. And so they have to treat this reaction. It's so common that it's generally treated before the infusion is given, but it's given every 2 weeks for the rest of the patient's life. So this patient, now that I think of it, this is a patient who might have something like a portacath or a PICC line, which are implanted. A portacath is a little, basically looks like a disc, basically with a dome that's made of some type of rubber or some type of plastic that's just below the skin, so they can give the infusion directly into it, or they may have a PICC line, a pure percutaneous intravenous catheter it's a central catheter that's placed usually through the antecubital fossa. And so on those patients, you definitely, we want to check with their physician, see if they need to be pre-meted with antibiotics. Because if it's within the first 6 months of having those put in, they're at greater risk of developing endocarditis because of that new implant that's in their body.
Great point.
Yeah.
Great.
See, always thinking.
That's right.
All right. So the next pharmaceutical is one that a lot of dentists may actually use in their practice, and that is a filler for skin. A lot of dentists across the country are doing skin rejuvenation procedures with hyaluronic acid products, hyaluronic acid gels. And what this new drug by Juvederm is called SkinVive.
And it's got lidocaine in there.
Yeah. So it's different in that it has a local anesthetic mixed into it. So the patients get, numb. It's a much less painful injection
Yes.
because it's got the lidocaine in it. And it's been shown that this can be used in basically patients with any skin type, whether they're dark skin, light skin, it doesn't matter. It's effective with all different skin types. Obviously, if you're using it, you want to stay away from patients that have had a history of anaphylaxis or multiple allergies. They could be allergic to this, obviously, if they have an allergy to lidocaine itself, or if they have an allergy to gram-positive bacterial proteins, because these are found in trace amounts in SkinVive.
Yes.
So
and of course, nasolabial folds, the cheek structures. These are some great areas where this can be injected, but we also got to be concerned when you're injecting these, making sure you're not in a blood vessel.
Yeah, absolutely. And if you do inject into a blood vessel, it's a big problem. And so you always want to have hyaluronidase in your office just in case, so you can break it down without it embolizing into the circulatory system. Also, and I'm sure when you took your class on injectables, they told you to be very careful in patients who are susceptible to keloid formation, hypertrophic scarring, hypertrophic pigmentation, if they're on any immunosuppressive drugs, or on any drugs that can prolong bleeding, like aspirin or warfarin.
Right.
Yeah. All right. Let's see. Should we go on to the next one? With number 7 is Opvee. Nalmefene. And so this is a new drug on the market for a very prominent in our world problem, which is opioid abuse disorder. And so this is a drug very similar to naloxone, but it has a longer half-life. So it lasts longer. So with naloxone, it tends to wear off fairly quickly, and the patient may have to be redosed if they become somnolent again.
But Jay,
this will last longer.
Right. Okay. But the bottom line to all the practitioners out there, if you do suspect someone with, opioid overdose or a narcotic overdose in your office because of either they are taking illicit drugs or you've overdosed them with IV medication, remember, naloxone takes about 2 minutes to work.
Yeah.
All right.
Yeah. So the most important thing when you have a patient, an opioid overdose, is, of course, recognizing it and maintaining the patient's airway. So while someone is going to get your naloxone, whether you're going to give it IM, intravenously, or nasal spray, you've got to maintain that patient's airway and probably ventilate them, open up their airway and ventilate them while you're waiting for that drug to come, because airway support is the most important thing. Most patients who die of an opioid overdose die because of respiratory arrest leading to cardiac arrest.
Right. And so that's why, I think people get, worked up because, hey, I gave the naloxone, it's not working. Well, hold on. You just gave it 30 seconds ago. You got to give it time to work.
Yeah.
You've got to maintain ventilation in that patient. Okay.
Yeah, very important.
And the other concern is if you start pumping them full of naloxone, now you wind up with the potential for opioid withdrawal symptoms.
Exactly.
And that's going to be brutal on that patient.
Absolutely. So the Opvee, just like the nasal spray, the naloxone nasal spray, which is, by the way, now available over the counter, is a pre-prime. So if you're using, if you're used to using like a nasal steroid spray or something like that, you have to prime the pump a couple times before you use it.
Don't prime this.
Both Opvee and naloxone are single dose. It's already prime, ready to go. Just one squeeze and ready to go. I read an interesting article the other day, and I think I sent it to you, John. It was talking about, do we need to redose naloxone? And what this doctor, who was an emergency room physician, said is, if you've given a couple doses of naloxone and the patient is not responding, your first thought should be, maybe there's other things in their
Another
system
drug.
too. Yeah, another drug that I'm looking at this patient thinking, oh, it's just an opioid overdose, but it could be opiates with barbiturates. It could be with benzodiazepines.
Yes.
Who knows? So if they're not responding, again, you still have to maintain that airway and oxygenation until EMS gets there, gets them to the hospital. They can do a tox screen and find out what is in this patient's body. And just like with naloxone, these are strong antagonists. And if the patient is on a partial agonist, so kind of a weak opioid, or if they're on a mixed agonist antagonist like Tolwyn, these drugs may not work all that effectively. And so if the patient is in a some type of rehab program and they're on buprenorphine,
yes,
for example,
right.
Naloxone and Opvee may not work as well.
And too, Jay, while you're ventilating, this is why I think you and I have said it over and over. Buy a pulse oximeter for your office.
Yeah.
Okay. All right. Have that, someone in your office should be trained to put that on the patient, because there's going to be a lot going on in your office. This is why Jay and I always say over and over, get ready for a medical emergency, because you are going to experience.
Yeah.
You're going
never
to
know when it's going to happen.
That's right.
Yeah.
And if you practice 30 years, go ahead and say that's a $30 million investment. Why would you not want to get ready for a medical emergency and protect that $30 million investment?
Yeah.
All right.
Yep. Because they happen when you least expect it, and you got to be ready.
There can be no excuses. I didn't know that was going to happen. Wrong. Sorry.
Yeah.
Remember, we talked about local anesthetic toxicity. That's a medical legal document, the package insert. You must be ready.
Right. And, just obviously, when we're doing IV anesthesia, general anesthesia, we have the patients on full monitors, pulse oximeter,
yes,
EKG, respiratory rate is monitored by end-tidal CO2, blood pressure. So we're constantly monitoring the patient. And even we have the same monitors in recovery. I have the same monitors plus oxygen in my consultation rooms up front, because sometimes we'll bring the patient up front to sit with their family member when they're a little bit more awake. And, I always tell my staff, especially the new staff members, when we're done with surgery, when we're done with our procedure and we put this patient to sleep or sedated them, they still have all these drugs on board and we are no longer stimulating them. And that's when the unexpected can happen.
Correct.
Yeah. So keep that in mind too. All right. Oh, I guess I skipped by that one, huh? Didn't I? Sorry about that. But we covered all this.
but Jay, think about it. What this tells us right now is how serious this situation is in America. We know that. We've had our prescribing habits change. We're now having to take all of these courses.
Yeah.
And those of you with a DEA license, let me remind you, you must take that one-time course, the MATE. MATE, and that's an 8-hour course. It's required by the DEA.
Yeah, it's a one time. Yeah, and there are no 8-hour courses. They're all like 1 to 2 hours. So you have to take multiple courses. Yeah. There's no one course that'll cover everything.
But Jay, there's going to be more products coming out down the road. There's going to be more of these that are approved OTC as well.
Yeah. This probably will eventually too.
I just encourage all dentists to know how to handle a narcotic overdose and a benzodiazepine overdose, because it may not happen in your office. It could happen outside the office.
Yeah. And I think 2/3 of the states in the US also require opiate education to renew your license every 2 years for as long as you're practicing.
Yes.
Okay. So our next drug.
Wow, you just mentioned that. Yeah, you just mentioned that, didn't you? Huh?
Brixadi.
Yeah.
Brixadi, I guess is how it's pronounced.
I like Brixadi. That sounds
more exotic.
Yeah, more exotic. Yeah, Brixadi.
So this is, nothing new. It's a mixed
another
partial agonist buprenorphine used for treatment of opioid use disorder.
Yep.
But the difference with this is it's injected subcutaneously, either weekly or monthly, and it forms a gel that is released over time. So it's basically a 2-week depot injection or a monthly depot injection.
So in other words, that the patient is being compliant when they get this medication, Jay.
Yeah,
Okay?
because buprenorphine tablets have to be taken every day by the patients.
Every day.
One of the problems we see in patients that have opioid use disorder, have psychiatric, psychological problems, is sometimes the medication they take to treat their problem does not make them feel all that great. They feel better when they're using the opioid, or when they're when their disease is, when if they have bipolar disease, when they're manic, or if they have schizophrenia, they like how they feel better sometimes when they're not being treated. So that's where a lot of these new psychiatric drugs and opioid use disorder drugs are now becoming are coming out in delayed release, timed release forms.
Right. And buprenorphine, we already know it is Suboxone or Sublocade as well.
Yeah, Sublocade is another one that has been around that's also a monthly injection. It's been around for a while. And this is a new form of it. It's also that's also a buprenorphine. The one thing with these depot injections that drug use or drug abuse practitioners need to be aware of is that when you're injecting this in the skin and it forms a gel, you always have to be conscious of intravenous or intravascular injection, because again, just like with the fillers, you can get vascular occlusive disease if one of these globs basically breaks off and enters the bloodstream, or
thromboembolic situation as well too.
Yeah.
I mean, basically, that's just like a plaque breaking off, leading to a heart attack or to a stroke.
Exactly.
Except this is man-made. This is iatrogenic.
Right. And so this is not a drug that's used for treating pain.
Right.
If you're using buprenorphine in the form that it's used for treating acute pain, like Buprenex, which is an injection, sometimes used in the emergency room, that's what you use. You don't use a long-acting drug for acute pain. And in fact, when they're deciding to or considering putting a patient on a long-acting depot buprenorphine, they're always tested first on the short-acting to make sure that they are tolerant to it.
And Jay, this drug here is just like the first one we mentioned. It's got its own Lumryz. It's got its own certification program as well.
Another REMS program. Exactly.
Another REMS program as well. So not anybody can just give this as well too.
Yeah, exactly. So they start on daily oral dosing, and then if that is successful, then they'll go to the weekly dose. And then if that proves to be successful after a few weeks, then they'll move them to the monthly dose for stabilization.
Okay.
Yeah.
All right.
Okay.
So, guess what? So we're just seeing more and more drugs in this category.
Yeah.
In the buprenorphine class, as well as naloxone or nalmefene class as well too.
Yeah.
Jay.
So if you do have patients that have opiate use disorder that's being treated, you've got to be very, very careful using any kind of CNS depressant. So obviously you're not going to prescribe them opiates, but even if you give them like a benzodiazepine or muscle relaxant,
because this is a class 3 drug.
This can interact with that and cause severe respiratory depression, or severe drowsiness, or basically decrease mental status. So another thing that with buprenorphine is this is a drug that can lead to serotonin syndrome. So you've got to be aware of that too, especially if the patient's on other serotonin drugs like SSRIs, as John mentioned earlier. Okay. So, and there are 671 drugs that are known to interact with Brixadi, along with 15 disease interactions, 1 alcohol-food interaction, which is actually with alcohol. 201 of these are major, 466 are moderate. And the disease interactions are those where GI motility is affected, can be from either a slow GI motility, depressed GI motility, or it can be increased GI motility, patients that have infectious diarrhea like pseudomembranous colitis, if they have liver disease, if they've had an acute MI, respiratory depression, adrenal insufficiency, hypothyroidism, a seizure disorder, renal dysfunction can all be affected, or they can all affect the drug level or the metabolism of this drug.
So bottom line, everything you just said, Jay, as a practitioner, I've got to be on top of my game when somebody comes in and they're on a medication like this. I just can't say, oh, I'm just going to prescribe my normal medications.
Right. You've got to be aware of what they're taking.
That's right.
What they're taking and why. So our next drug is a drug that has been in the news for a long time, and that is Paxlovid. But what is different now is that as of May 25th, last month, it is now has been fully approved by the FDA.
Yes.
Where it was on an EUA, an emergency use authorization till this point. It still is on an EUA for people under 12 years old, or I'm sorry, under 18.
So bottom line, Jay, I try to tell people Paxlovid is to COVID like Tamiflu is to the flu.
Yeah.
All right. As soon as you test positive, the sooner you get on Paxlovid, the better you're going to feel.
Better the outcome. Exactly.
That's right. Better the outcome.
Yeah.
Just like Tamiflu is. I mean, if you wait 48 hours after getting the flu to get on Tamiflu, you just wasted your money.
Yeah.
All right.
You should patients get on it as quickly as they can once they recognize the symptoms. And they're going to, a lot of pharmacists in a lot of states are actually authorized to prescribe this for patients.
What I like about this drug, Jay, is the fact of the secondary drug in there, ritonavir. Okay.
Yeah.
Ritonavir is put in there strictly as a strong CYP3A inhibitor. Okay.
Yeah.
So it helps Lumryz to get into the system and do its work.
Right. So that is what actually inhibits replication of the COVID virus, the SARS-CoV-2, by basically stopping viral replication. And the ritonavir prolongs its duration of action.
That's right.
It inhibits its breakdown. Okay. So patients who are on Paxlovid, you've got to be careful for the most of the time, if patients are on Paxlovid, they're not going to be coming into your office. But if they do come in on an emergency, you need to be very cautious if they're to give them any kind of sedative like midazolam or triazolam can interact and cause respiratory depression or other problems. And also some narcotics like Demerol.
Because of the CYP3A inhibitor, it prolongs that effect.
Yep.
That's right.
And patients are told not to crush or chew or break the tablets. They're going to take all three together twice a day. So it's two of the nirmatrelvir and one of the ritonavir. I'm not sure why it's not combined, but they're taken separately but together.
Yes.
Yeah. All right. Side effects mostly with these drugs are allergic reactions, and sometimes things like just change in the patient's sense of taste or smell, diarrhea, sometimes elevated blood pressure, sometimes muscle pain. And again, if a patient is taking Paxlovid, you do not want to give them any type of benzodiazepine or narcotic. All right, our next drug on our list is Inpefa.
And final drug too.
Oh, Inpefa. That's right.
What a name.
So I wonder how they come up with these names. I think they just have like dartboards with like different like single syllables, and they just throw the darts and whatever.
Well, actually, Jay, the pharma company has a marketing team that comes up with it. Then they have to submit it to the FDA's marketing team, and then they make the final decision on the drug name.
Yeah. But I think that's how the marketing team decides on the name. how they come up with the name, because some of these names seem so random, like Inpefa. I mean, who would come up with that?
Okay, for example, I'll tell you Vicodin.
Yeah.
All right. It's hydrocodone. It's the
Right.
original hydrocodone.
Yeah.
Hydrocodone supposedly was 6 times stronger than codeine.
Yeah.
So the VI Roman numerals in Vicodin is 5 plus 1 is 6. And then codeine. All right. Vicodin or codeine. Vicodin. 6 times stronger than codeine.
Yeah.
Right?
So sometimes the names names make sense,
Right.
or for a specific disease. The name may have something to do with that disease, like with Advair. It's used for preventing asthma attacks.
So what's so cool about Jay with Inpefa? What was it originally indicated for? Diabetes.
It was an SGLT 1 and 2. So sodium glucose co-transporter 1 and 2 inhibitor. And it was found in patients who were admitted to the hospital with heart failure, that it actually reduced the incidence of readmission for heart failure in patients who were on these drugs. So now, in addition to being used for heart or just for diabetes, like Invokana, Forxiga, and Jardiance, it's used specifically to prevent recurrence of heart failure in patients who have left the hospital.
Okay, so bottom line there, Jay. So, okay, here we go again. All right, a patient comes in, you don't do your homework, and then all of a sudden you see something on their medication. Hey, what's Inpefa?
Yeah.
All right. Okay, we prefer you not to do that, but I mean, if that's the way you practice, so be it. What do you take that for? And then they say for heart failure. All right. You've got a sick patient in your office.
Yeah, not just for diabetes, but they're taking it for heart failure. Exactly. So you always have to dig into their medical history, especially when you see something that you're not sure what it is. Look it up. If you don't know what the drug is, don't just gloss over it. Look it up. It may be critically important.
I like how you said you did it before in the past. You have your assistant go in, collect the information, come out, and then you scan through your medication just like I do.
Yeah.
And if I see anything, I had somebody in here the other day in the office, 22 medications. All right. And I'm just going through
not uncommon these days, at least in our practices.
No. That's going to be a common thing, Jay.
Yeah.
All right.
And when the assistant comes to me to review the patient's medical history, why they're here, and medical history, I look up the name of the drug if I don't know what it is with them there, so that they know what it is too. And I also educate them. Let's say the patient is on a trying to think, SGLT 2 inhibitor. Why is the patient on this drug? What is this drug for designed to treat? And it's usually diabetes.
Okay, so Jay, there we are talking about this indication. I mean, we just said it reduces the risk of cardiovascular death. I mean, a patient could die in your office while treating them on this medication. Okay.
I mean, diabetics are at high enough risk anyway, but
absolutely. And then, or for urgent heart failure. So if any of you out there doing IV sedation, you've got to be extremely careful. You don't fluid overload these patients. Okay.
For sure.
Be very cognizant of that. Trust us on this.
Yeah. And what's interesting is these drugs will work by increasing the kidney output clearance of glucose. So we always used to test for diabetes by doing a glucose dipstick urine,
right?
And these patients will have an elevated urine glucose because of the drug they're on for their diabetes. Another interesting complication that it can cause is necrotizing fasciitis of the perineum, otherwise known as Fournier's gangrene. And have you ever seen that, John?
Well, I had a case in residency. Actually, I did an article on it. I wrote a paper, and it got accepted and published, and on cervical facial necrotizing fasciitis. All right, Jay, we're talking about and just within 24 hours, it just eroded all of the strap muscles in the neck. And I'm referring to like the sternocleidomastoid and those muscles there completely eroded all of them.
Yeah.
Okay.
And, when my first couple days on my general surgery rotation as an oral surgery resident, we had a patient with Fournier's gangrene. And I got to tell you, just like with cervicofacial, it is a difficult disorder to deal with.
Yeah,
and
you're always
very
concerned.
debilitating.
I tell you, it's multifactorial.
And patients can die from this.
Oh, absolutely.
Yeah.
And, when you have that patient with a cardiomyopathy, type 1 diabetes, you're setting the stage for something like a cervical facial necrotizing fasciitis.
Yeah, for sure. For sure. That's a major complication of this drug. And as far as drugs that will affect Inpefa, digoxin, because it'll increase the absorption of digoxin.
Right.
Rifampin may actually reduce the effectiveness of sotagliflozin, and lithium concentrations may be decreased if the patient's given this drug, as with, I think, other SGLT1 and 2 inhibitors. And then they haven't really tested as far as herbal medications, vitamins, that type of thing, which, as we all know, herbal medications, especially if they start with a G, can
G
have
or St. John's wort. I'd be very concerned about that drug.
Can have serious interactions with bleeding, and also with CNS depressants, benzodiazepines, and narcotics we may give our patients.
Yes.
All right. So let's move on to our medical emergency of the month.
Awesome.
All right. And
so, Jay, our medical emergency of the month, it could happen anytime at any day in a dental office. All right. So as I want our audience to start thinking about this, we work with small instruments. Or it could be a tooth, or it could be a crown, or be a piece of bone, or it could be a 2x2 gauze.
Yeah.
All right. And when this happens, you don't have much time to correct the issue.
Yeah. That's why, at least when we teach surgery, especially IV sedation, surgeons always have some type of throat protection in place. Airway protection in place.
Right. Oral pharyngeal screen, throat screen, whatever you want to call it.
Yeah.
Have it in place. All right.
Exactly. Because you never know when something's going to slip.
So what is it, Jay? What's our emergency?
So our emergency this month is foreign body obstruction of the airway. And I guess I should have made an enlargement of this slide, which I forgot to do. So let me go back to it. And actually, I'll make it a little bit larger on my screen, so we can go through these.
So while you're doing that, Jay, I like to call foreign body obstruction, or FBO.
Yeah, FBO, foreign body obstruction. The obstruction could be anything from something that we're using in our office, an instrument or a tooth, or food.
Yes.
Right? That's the most common.
Or it could also be swelling as well, too.
Airway swelling because of anaphylactic reactions. Yeah.
So I like to call FBO what I refer to as a 3 minutes to live medical emergency. There are 3 of these in dentistry I like to talk about, and Jay and I have mentioned these in our other talks. They're foreign body obstruction, they're anaphylaxis, and sudden cardiac arrest.
Yeah.
You got about 3 minutes to get everything right. So here we go again. We go back to what we've always said, Jay. If you don't practice, how do you think you're going to behave when one of these occurs in your office? And like you said earlier, we can't tell you which medical emergency it's going to be. We can only hope you'll listen to us and get yourself prepared and ready.
Yeah. And your staff also. Make sure your staff is also prepared.
It's not an I problem. It's a team issue. It's handled as a team. All right. I mean, I hate to say it. I mean, we did the webinar, patient dies in your office. Do you want a death on your hands because you weren't ready? We looked up the statistics. Usually most practices close in about 30 days after losing a patient.
Yeah. Yeah.
And there goes that investment that you worked so hard for too.
Yeah. Because patients will stop going to you.
Yes.
They'll say, oh yeah, especially because you can guarantee whether you're in a small town or a big city like LA, if you have a death in your office, it's going to be on the news and everyone's going to know about it. Every dentist is going to know about it. Every dental specialist is going to know about it. Every patient of yours is going to know about it. and they may stop going to you. And if you're a specialist, they're probably going to stop referring to you.
That's correct.
So it's the death of a practice. Exactly. So the first thing you're going to do if the patient has a foreign body obstruction is activate EMS, 911. Get that going ASAP. Right.
And that's Jay, if they're unable to speak,
Yeah.
they can't cough, they're not getting any air, you're seeing cyanosis. Okay. So yes, call 911. Again, that's one of those 8 deadly failures, Jay, that we talked about in our last webinar about this. Why are we so embarrassed to call 911?
Yeah.
All right. Because it's going to take them a little time to get to your office.
Yeah, for sure. And as John said, if the patient is breathing a little bit or they're able to talk, they only have a partial airway obstruction.
Don't intervene. Let them try to cough it up.
Exactly. Let them try to cough it up, but be advised.
But be ready.
That may become a complete FBO in a
complete airway obstruction. Absolutely. So you've got to be thinking, okay, what's next?
Yeah. So you're going to call 911 immediately. You'll make sure the patient's supine. You're going to do all your airway maneuvers. You're going to jaw thrust, chin lift, and see if you can see the foreign body and grab it. If you are trained to use a laryngoscope to bring the tongue forward. Laryngoscope is
Jay,
basically...
let me interrupt you right there when you said if you can see the foreign body. This is why I'm a huge fan of the McGill forceps being in everybody's airway kit. I mean, you need to practice picking up teeth with it and all that, because now you're in a situation you've got to get it right the first time, because if they swallow, it's gone. Yeah. And did they swallow it or did they aspirate it?
Yeah. Okay. You hope they swallowed it, because that'll pass through. And I read an article not too long ago that basically anything will pass through. It's very rare, even something sharp, even, safety pins that are open or straight pins that are swallowed, or nails. Very rare they perforate the GI tract. They usually pass through. So hope the patient swallowed it. But if this happens and you think it doesn't look like the patient aspirated, they're not coughing afterwards, their O2 sat's not dropping, you still want to get a chest x-ray and what's called a KUB, an abdominal film, kidney, ureter, bladders, to verify that foreign body, that crown or whatever it may be, is actually in the GI tract and not in the lung.
Do not disclose this from the patient. Okay. If this happens, if you lose a crown, say, well, I think you're okay. Or they've got, as Jay said, they've got to go to the emergency department. Yeah. They've got to get these scans. Tell the patient what happened. Document.
Yeah. Don't just, oh, you're fine, go home. You have to follow up with x-rays with the emergency room visit. Also, so if this goes on and you're not able to, patient's not able to breathe, you have complete obstruction, you're going to try to ventilate the patient, try to get some air to move, however you can. And if you have a laryngeal mask airway, that's something you're going to insert and ventilate the patient.
Jay, what about what I sent you?
The patient.
What about the new DPA, distal pharyngeal airway, that I sent you the other day?
That was kind of interesting. When I saw that.
I actually had the company send me some of the products. Yeah. Very easy to place.
Yeah. I don't know how you avoid air going into the stomach also, though, with that, because it doesn't block off the stomach like an LMA does.
Correct.
Yeah.
But the bottom line is, again, something like this, you're going to need a pulse oximeter, make sure you can see what their oxygen saturation rate is. Yeah. And can you ventilate?
Can you ventilate? And does the patient have a pulse? Do you need to start CPR? Because if you forget about, you're so caught up in the moment of trying to ventilate that you're ignoring whether the patient has a pulse, you're going to lose the patient.
Yeah, and CJ, that goes back again, what we're talking about, the 8 deadly failures. I mean, we could easily take it to 10 deadly failures. The inability to do BLS. Yeah. All right. How many times have we looked at case reviews, Jay, that BLS was not done on the patient? Yeah. And I mean, this is something that it's mandated for all of us. And that's why I like to see people train more on BLS. Be very efficient at this, because you're going to have to do it and do it right.
Yeah. Yeah. So if the patient is still conscious, you can do the Heimlich maneuver, traditional Heimlich maneuver on them. If they are unconscious and they're supine, either on the floor or on your chair with a chest with a hard, firm backing, you can do the Heimlich maneuver with them supine, which is really the only way you want to do it when they're unconscious.
Yeah, because I mean, you're going to have to do abdominal thrust when that patient goes unconscious. The ball game's going to be really tough to win there.
Yeah.
Okay, all right. While they're still, if you have to do it while they can still possibly stand for you, and because once you're on the floor, now you're having to do hard abdominal thrust trying to get this up.
Yeah, trying to get it to be kind of blown out. As a last resort, there is cricothyrotomy, but this is not something I would recommend to someone who's never done one.
Correct.
Or not, if you're not familiar with the anatomy, or you haven't done this type of surgery to open up. In our training we do tracheostomies, and so this is part of our training. We're much more comfortable doing a cricothyrotomy in an emergency, but make sure as part of your training, that especially if you're ACLS certified, Advanced Cardiac Life Support, that you learn how to use this life-saving technique. And that's, again, this is why it's so important to call 911 right away.
Absolutely.
Yeah.
Okay.
Because the paramedics may be able, they may be able to do the cricothyrotomy if necessary. And as John said, 3 minutes is what you've got.
And when you're if you've trained people in your office, I like to call them Rover 1, Rover 2. That's your front office personnel. Somebody's assigned the 911 duty.
Mm-hmm.
They need to tell them, we have an airway obstruction in Dr. Reznick's office. Yeah. We need help now. Yeah. All right. So this is a top priority for them to get to you as soon as possible.
Yeah. And you'll send a member of your staff down to meet the paramedics so they can find
that would be Rover 2
as possible.
That's right. That's right.
Yep. All right. So
PharmaDent, there it is. 15 modules. Why would you go attend a pharmacology lecture somewhere when you have something like this, Jay? Huh?
I don't know. I wouldn't have to travel. I wouldn't have to stay anywhere. I wouldn't lose time out of my office. I can do it at night. And so we've got basically all the most common drugs. Antiarrhythmic drugs, congestive heart failure drugs, emergency drugs, hypertension drugs that you're going to come across, broken down into 15 modules, and we educate you about these drugs, so you're very familiar with them.
And the disease state. We go over patient red flags and medically compromised patients. Mm-hmm. I'm very pleased with what we've accomplished here, Jay, because especially on the drug to drug, or I write this drug and the patient's on that drug. Yeah. Okay.
Drug interactions. Yeah.
Right.
And you get CE credit from the comfort of your living room or your office or wherever it may be. All right. So how much are the modules, John? I forget.
$299.
$299 for the whole thing. For
the whole thing.
For all 15 modules.
Yeah. Now, if you buy it individually, I think it's $25
each. That's what I'm thinking. But it's better deal to buy.
And speaking of lecture, we got you doing our dental office medical emergency simulations, 5 separate modules. I appreciate the feedback we got the other day from somebody that took it. And
I thought that person, great. Yeah.
Yeah. It doesn't have to travel. He can go over it with his staff.
Yeah.
Because that's the biggest problem with all these I don't say all medical emergency lectures because it's hard to find them nowadays. Yeah. Most dental meetings won't have one, even though it's to me, I think it's the most important lecture there is. Yeah. We want you to be able to place that implant and all that, but you got to have a practice to be able to do that. All right. So if you have a medical emergency going bad, you can lose that practice. So
another advantage is you can go back and watch the video, go through the course over and over again as much as you want.
Because when they do have a lecture at some meeting, are you going to pay for your staff to go? No. So you're going to lose the benefit of the team being ready here.
Yeah. In fact, I use the DOMES videos in my office for my new and current employees.
Same here. Absolutely. Yeah. You can't have enough of this stuff because if you're relying on dental school memory, oh boy.
Yeah. Yeah. And this is also available on dentallearning.net, as well as my opioid course.
Yes.
So what I did was I put together a course that is 3 hours in duration, because some states require 1 hour, some 2, some 3, and they all have different requirements of what has to be covered. So this course covers everything for every state. Now in California, you have to take I have a separate course for California, because California, you have to be a registered provider in order for you to get the credit.
Yeah.
So in California, we was a course, and I just did one for New Jersey a couple of weeks ago, and I'm doing Ohio in a few weeks.
Awesome.
So we have specific courses for them. So that's also available on Dental Learning. And then, as John mentioned, our patient dies in your office. What happens next? Another important educational tool to go over and learn what you're going to do should this untoward event occur in your office. So hopefully it never will, but if it does, you got to know what to do. You got to know how to handle it. All right. So,
but Jay, I'd like to announce we got some exciting news hopefully coming here in next month. We'll be able to share with the audience what you and I are working on next.
Yeah, actually, we're working on a couple things.
Oh yeah, it's going to be awesome. Just going to be great.
Yeah. So our next episode will be July 14th. Again, the second Friday of the month. Yep. Every month, we'll talk about new drugs that have been approved in June, and we will have a new medical emergency.
Thank you so very much for attending. Thank you.
All right. Thanks a lot. Where are we going?